I grew up in northern part of Pakistan, and of course, like any other child, my hobbies were to play tennis, and in Pakistan, cricket is quite popular, so I used to play with my brothers cricket. And you would be surprised to know that from very young age, like I used to play doctor with my friends. So I guess I had this thing in me to become a doctor, from a very childhood. Even at that point, I had no idea, but just it was in me. Basically, as I reached, I think, by my high school, I started noticing more in my community that infants are simply dying from diarrhea, or women passing away during deliveries. That really triggered my interest, like how could I make a difference? How could I help these neighbors or these people around me? So then I decided to take pre-medical, and of course further pursued my career in that direction.
Amazing. So you went to medical school in Pakistan?
Yes, yeah, I did go to Allama Iqbal Medical College in Pakistan. I did my internship from there, and I did master in public health after that because I really wanted to make changes at population level, and then decided to learn more about hospital administration, like how I could expand the access to all the underprivileged communities. For that, I needed to learn the administrative or financial part of health management. Then I decided to pursue my master's in business administration. I went to States, did my MBA, and I got very lucky as I had the opportunity to do health policy internship with Mayor Bloomberg, who had done amazing work in terms of public health intervention. So I did my health policy internship there. By that time, our family moved to Canada, so I immigrated here, did my residency from University of Ottawa, and yeah, here I am today. Yeah. One day, I was working in emerge shift, and the police brought a patient with severe leg infection or cellulitis. So of course, I was working as a resident, and this patient was crying nonstop in pain, and then he started, screaming and yelling for more painkillers. I overheard staff saying that this guy had an opioid addiction and he's just exaggerating to get more painkillers. Like, it almost felt in that moment that they literally dismissed that patient. He was sort of invisible, though he was screaming so loud. At that time, of course, I was just a resident, had no knowledge about addiction medicine, and unfortunately, we didn't have any addiction consultancy service at that time. But just looking at the whole situation, I think it shook me that he was treated so differently. Like, at least they could have paid attention, at least they could have provided him some compassionate care, but no. So that opened up concept to me that how stigma or personal bias or lack of knowledge or training about addiction or person with substance use disorder can cause a blockade in providing rightful or compassionate care to the patient. So I think that was an awakening moment for me, that I wanted to be advocate for these patients. I wanted to change things because I could see the suffering and misery in his eyes, like how he was treated so differently. And after that, I asked my program director to offer me additional training in addiction medicine. So I did full year in addiction medicine training. And I became so passionate in addiction medicine that I also pursued my American boards in addiction medicine just to be an expert in the field where I could provide the best, up-to-date, evidence-based treatment services to this population with respect and dignity. So I think that incident really changed the trajectory of my whole career. I have the first-hand exposure of the evolution of addiction medicine throughout my career. Despite advances in the addiction medicine treatment, somehow the stigma remained persistent over the course of last 10 years at least. Although it is reducing in terms of its prevalence, but I have noticed that people have come around. There is more acceptability in the society. Like people now understand that this is a chronic brain disease and it is treatable. So I think this is a huge positive step in good direction. So
You mentioned inner stigma, and one, how would you explain stigma, number one, and how do you find, as a medical professional, how that impacts the people you're trying to treat?
Well, I have seen the stigma or call it a judgmental approach where you already come with an underlying assumption about a patient once you know they have addiction or any substance use. And that changes your whole course of treatment, because this is something as a, call it a provider bias. And then you somehow you treat that patient differently as compared to someone who doesn't have a label of addiction. And unfortunately, I have seen that personal bias in many of the frontline workers, because I have worked in all settings, emerge, ICU, outpatient, inpatient, in the community, and I have patients who have shared their first-hand stories with me as how they were treated with a judgmental approach, or they received a biased treatment. For example, I had a patient who does not drink alcohol, but she one day came back home and she started vomiting, and after that she became so dehydrated that she almost fainted. She called 911 and they came and they were surprised, like, what happened, why she fainted. She brought a collection of the wine bottles with her because she uses it for different crafts and you know. So those empty bottles were sitting in their room, and they just literally focused on alcohol. How much did you drink? What were you drinking before you fainted? Like, just having those empty wine bottles, they just automatically thought, oh, she must be a heavy drinker. They just attached stigma. and unfortunately, she was sent home without having a complete workup. And 4 days after that, again, she got admitted, and turns out it was cholecystitis. That was, she was vomiting nonstop. So it was not something, but you see, our assumptions, even when you approach the patient, underlying assumption from a healthcare provider perspective or frontline healthcare perspective, it changes how we interact with patient and how we treat the patient. So I would advise my other colleagues that they should use zero assumption approach whenever they are treating any patient, and try to use compassionate and non-stigmatizing language, even if you become aware that patient has a substance use disorder. Like, instead of calling them a junkie, or you are high, or oh, you are just an alcoholic, like avoiding those terms, because that would cause a barrier. You would not be able to develop a rapport with the patient. And then many times when you approach with that biased mind, or judgmental language, people would not seek out treatment. They would try to, move away, because nobody wants to deal with a person who is really using such abrasive language towards you. So I would encourage all the colleagues that, first of all, we need to work on our attitude. And for that, we have to, I think, be more educated, because the more you know that this is a treatable disease, this is a chronic brain condition, it's not a moral failure, it's not flaw of the character of the person, but you are just treating a medical condition. So don't treat them differently. We often ignore the underlying structural or social determinants of health, which are responsible for addiction as well. For example, if somebody who's unemployed, someone who has been a victim of human trafficking or sex trafficking, someone who had returned from war and who had witnessed, serious things there, which had led to PTSD, all those people, they would be at high risk for developing substance use for various reasons, because someone maybe to cope with their anxiety and depression, someone to treat their emotional pain they have gone through that time period, someone who did not have any social support or had been lonely in their life. They don't know how to cope with their anxiety, and they just use the substance to minimize their anxiety. So there have been different reasons for developing addiction. It's not just the substance use. So I think we need to apply social determinants or structural determinants lens when we are examining addiction as a problem. So I know doctors are becoming increasingly busy, but addiction is such a field where you need to spend time with your patient, because spending time establishing a rapport, building a relationship where patient can trust and share information with you, so that you understand their stages of recovery, or whether they are ready for change, or what are their goals, and why they are behaving in such a way. That spending time with the patient really provides you a lot of information where you can work with them and customize the care according to their social situation as well.
Yeah, I've always found the data paints the picture, but the stories give you the context of the picture. And that's been my my minimal time being a frontline worker. Mm-hmm. That's how it would get through to me. Was if and taking that approach of empathy and being like, I just want to understand where you're coming from. See, once I find you hear them, you hear them out, and you meaningfully, and they're like, oh, you actually care about my well-being. That is a
yeah, actually, people don't care how much you know. They know that how much you care. So that is the turning point. Once they know, like, you are really caring for them in a compassionate way, that opens the door to share more information. And I think it's basically a collaborative relationship. It's not like, here is the prescription, go ahead. No, at least in addiction medicine, things do not work that way. You need to understand your patient better, because till the time you don't understand patient narrative, their socioeconomic background, you would not be able to customize the care as per their needs. And that is the missing piece when we are providing these addiction services. For example, if I have patients who are working in camp areas, they are gone for 3 weeks or 4 weeks, you need to understand their limitation, that they would not be able to attend, frequent appointments, or they would be needing more flexibility in order to facilitate their social productivity. So till the time you don't know all that information in detail, like how it is important for them to keep their family and their livelihood going on and keep their children custody, all those things which matter to your patient, I think you need to pay attention to all those little details. The more you know your patient, the better you can provide the care. I think addiction medicine, harm reduction plays critical role, because it is one of the pillar of Canadian drug strategy as well, because this is an approach, basically, like, we define it as a program or policy which is aimed at preventing the drug-related harm from substance use without requiring the cessation of that substance. And basically, we are trying to mitigate any negative consequences of drug-related harms in terms of social, economical, or physical ways. So harm reduction, I think it's a broader approach where you accept the patient where they are. You are not changing them from the get-go. No, it's a continuum of care, because people have their own autonomy. They can make rational decision for themselves. So harm reduction really respect that autonomy and their ability to make decision at their own goodwill, without forcing them to change the way the provider wants, because it recognizes that people are in different stages of change. Somebody might not be ready to quit from the beginning, but maybe down the road they find, yeah, maybe my goal now is abstinence. In the beginning, it might be reduction of use. At the very beginning of my career, when I started practicing as addiction medicine physician, I was consulted again in an emergency room. For a very young patient, she was 24-year-old young immigrant female who was admitted with liver cirrhosis. So at such a young age, so I was really devastated to see her blood work and ultrasound that, anyways, when I sat down with her, interviewed her, I came to know, like, of course, she was a new Canadian. There was some linguistic barrier as well, lack of social support network, and again, not knowing about the negative consequences of the substance, because she thought she's alone, she was depressed, missing her family and all that. So alcohol became the coping mechanism for her to numb her emotional pain, anxiety, and because she was all alone in this country. Unfortunately, like, she had no access to the family physician. She was an unattached patient. So after seeing her, I realized that, it's not our duty to just treat patients in the hospital or in our clinics. It is our duty to also focus on the people outside so that they don't become patients. Like, prevention is an important part of the addiction medicine. We often forget that, because all the time when we are describing addiction, like, it's providing treatment, more clinical services, but prevention is huge, and we need to focus on that. So I think after seeing that patient, I became more involved in preventive work as well. I reached out community partners, both in Alberta as well as in Ontario, and arranged community level webinars to provide education about all the common substance, whether it's opioid, alcohol, what are the negative consequences, and what are the available treatment options. This young girl, she had no idea she could seek treatment. There are anti-craving medications. So this is important knowledge and education which should be broadcasted at population level. I also became more involved in teachings and started teaching medical students as well as residents, so that I could train them for better addiction medicine services, because they are our next generation of physicians who would be working in different settings, whether it's primary care as a family physician or in emerge room, or whether, as a surgeon or gynae ops. Everywhere you interact with these patients, and early identification, early intervention is the key. We can really prevent all the negative consequences of any of the substance use, and we can promote healthier communities. So I guess prevention is a critical part of addiction medicine. So as much as we focus on treatment, harm reduction, we need to focus as healthcare provider more and more towards prevention too.
So the girl that you had spoken to, or you had treated, do you know what ended up happening? Where did that end up leaving off for you? If you don't have to share if you don't want to, but it was just a question. I was just wondering if she was able to get engaged into treatment or.
Yeah, so we were able to engage her in treatment, and we started her on anti-craving medication, connected her with other resources as well. counseling so that she's more engaged, both individual and group counseling. And also, cost was another issue. Since we are already talking about the social determinants of health here, that this person who was unemployed, new immigrant, she didn't have the money to afford these expensive medication. So we reached out to community organization, and they sponsored the 3-month medication coverage. So the outcome was good. This girl has done really well and stayed in treatment. She was really engaged in treatment, and later she was working, so became a really productive member of the society. So the outcome was really good. So
that's great. Is there an experience within your career where you had lost somebody who you were treating, and that it had an impact on you personally, and how did you move on, or how did you cope with that moving forward?
I think one of them that had profound impact on me was a young kid, 21-year-old, who identified himself as member of gay community, and he was struggling with opioid addiction. So we engaged him in treatment, but unfortunately he did not have stable housing because his family was not accepting him while on treatment. To them, it was like, no, even the substitution treatment is sort of an addiction. So things didn't go well. He was kicked out from his home. We connected him with the social worker and helped him to get into a temporary shelter. But again, he faced double discrimination while he was in shelter. First, being on opioid treatment, like you are an addicted person. Secondly, he was bullied badly for being gay while he was in shelter. So this guy was stable on treatment, but he left shelter and overdosed on fentanyl intentionally. I think that had profound impact on me. I really wish I could have done something differently. Maybe the social worker could have sent him some shelter which had more acceptability, more openness to have, person who have been identified as member of gay, lesbian community. Probably, like, what could I have done differently to support him? It happened within a short span of time, and I couldn't. I think I felt desperate when I learned about his unfortunate death. So I could never forget his face. Unfortunately, yeah, it happens because in our field, people are in different stages of change. We try our best to engage or retain them in treatment, but for various reasons, and again, many times those are social determinants of health, like somebody was in rural area, somebody didn't have transportation, or someone couldn't afford the medication cost, or someone who was working and unable to attend the clinic after hours. So for various reasons, people who couldn't continue treatment and fell off the treatment and ended up having overdosed and passed away. So I know as a physician, we devote our career to do our best to improve the health and longevity of the people's life, but we also come across with grief and loss. So, and our medical training doesn't provide us any training during the medical school how to cope with grief and loss. But I think we learn as we grow, as we experience, we learn that we are human beings at the end of the day as well. So I let my emotions happen. I know I have cried for my patients once I became aware that they have passed away. We remembered them, and often we arranged a debrief session with other colleagues who were also involved in the treatment, the counselors or social worker, to remember those people, because that's the only way you could remember, because those patients will stay with me. That's how I have coped. COVID was really a rough time for all the healthcare providers in general, but more so for addiction medicine specialists, because it almost felt like that during pandemic we were seeing a parallel opioid epidemic. So they both collided during pandemic. We had seen increased rates of both mental health and addictions, because our emergency department were overwhelmed with the volume for opioid overdoses, opioid withdrawals, alcohol intoxication, alcohol withdrawals, more psychosis with stimulant induced psychosis, more depression, because COVID made people so isolated. Many people became lonely, right? People who were homeless, they were also stuck in their whatever shelters and all that. So they didn't have any social networks. On top of that, we had reduced services for harm reduction, for safe supply, for naloxone kits, reduced hours for pharmacies, and people had trouble to access their medication, methadone, Suboxone, like people who were on daily, although we became very flexible, provided carries, but still there were people who we couldn't give for safety reasons. They were still on alternate dosing and all that. Also, people were unable to access other services for substance use disorder, the counseling services, or even the doctors became mostly virtual, right? So people who didn't have phone, how they would be accessing those virtual care. So I think together, all these factors contributed to the accelerated rate of cases during the COVID. And that's why we saw like a 79% increase in opioid related deaths in Ontario. And 1 in 6 was in homeless person. So the COVID really affected marginalized population disproportionately. It was a tough time for patients, for communities, and at the same time for healthcare providers. And I remember in COVID, I work 7 days per week, morning, and I don't know, till late night, like I provided services to all the 5 hospitals, the detox, the RAM clinic. Seriously, the volume was too much. It was very difficult time during COVID. The pressure were really high to manage all those cases presenting in the emerge, because many of the clinics got closed, and again the people were not able to access the clinic and other services. So all of those people also presented to emerge, because where they would go.
What would you say to other healthcare providers getting into addiction medicine or wanting to get into addiction medicine?
Yeah, I would say use compassionate, culturally competent, and non-stigmatized language with your patients. If you really want to engage them, if you really want to build a trust relationship with your patient, you have to be very nice with your patient, and always be an advocate for your patient, even in your documentation as well. Your documentation should speak and advocate for your patient, not against them. So that is also a form of advocacy. So fight for your patient and give them a chance, and be flexible. The guidelines are there, but the person is right in front of you. There is always a room. You can always make some flexibility, some adjustment in the treatment plan as per your patient. So be nice to your patient.